Good afternoon and welcome everybody to today's event on the latest Telehealth MBS item number changes jointly presented by CoviU and Synapse Medical. My name is Margaret Faux and I'll be your host for today. I'd just like to start by acknowledging the traditional owners of the land where I am standing today. That is the Gadigal people of the Eora Nation, and I pay my respects to their elders, past, present, and emerging. Just briefly, a little bit of housekeeping before we kick off. Feel free to pop any questions in the chat on the right-hand side of the screen, and I will try to get through all of them at the end of the session. I also have a colleague, Andy from CoviU, who's tucked away there in the background. She will be helping me with the chat, managing the chat as well throughout this session. A link to the recording and the slides will be emailed to everyone after the webinar by CoviU, so just keep an eye out on your inbox. So I'll just tell you a quick overview of what today's about. So as you know, there's been some recent changes to MBS Telehealth Items. It can be very confusing and overwhelming. So today I'm going to get you up to speed on what exactly has changed and what it means for everybody. We'll be covering GP specialists and a little bit about allied health. Just quickly, one of the things we won't be covering today is we will not be discussing the merits or policy considerations about the telehealth item number changes. That's a discussion for another time and another forum. This is intended to be very, very practical to actually help you know what you can and cannot do. So it's also a rapid fire session, which means that we're hoping to get through this in 20 minutes flat with a little bit of time for questions. We might even get the questions done in 20 minutes. So I'm going to go very, very fast. So we may not be able to go into too much detail. If you have a really curly question for me about a specific item number or problem, we may have to deal with it offline. So on that note, let's get going. So a couple of overarching things first. This is a very complex and fluid environment at the moment. The lawmaking, the pace of lawmaking at the moment in this area is like nothing I think this country has ever seen. I can't imagine any other area of law that is changing and has been changing as quickly as this over recent years. So I just want to actually give a big shout out to my legal colleagues who are legislative drafters down there in Canberra, who are probably finding it very challenging themselves to keep up to date with all the legislative changes and keep track of what law links to what other law. So those of you who know me know that I always refer to law, not to necessarily what the resources Medicare provides are, because they're not the law, they're an interpretation of the law. But today I'm going to refer to all sorts of things because I have no option, because some of the things that are on the Medicare website or the minister has announced have not yet been enacted into law. We've actually found over the last couple of weeks, since the 1st of July in particular, is that the most reliable piece of information that we have in our organisation is actually the data file that we receive regularly, which we upload into our medical billing online software, because that's really a source of truth. That tells you what item numbers are and are not available, because that's the data file that we receive and install into our software. So I'll refer to that a little more shortly. So a couple of overarching things now. Just Medicare 101 refresher. I'm sure most of you know this. When you're providing telehealth services, it has to be safe and clinically appropriate to do that. When you're providing any Medicare service, it has to be a clinically relevant service. A clinically relevant service is defined in the legislation as a service that is necessary for the treatment of the patient as judged by peers. Necessary is the key word. So just to be very, very clear, Medicare reimburses services that patients need, as opposed to services patients may want, and as opposed to services that may be available and you could provide them, but the patient does not need them. So the best way to understand that is just to be very clear, always ask yourself, what does this patient need clinically need, medically need, as opposed to how much can I get. So because Medicare operates, and also remember always that Medicare operates as a patient insurance scheme, not a provider payment scheme. So just keep those overarching principles in mind, because they apply to telehealth services just like they do to any other service that you might provide under the Medicare scheme. Also remember that if you're charging gaps to patients, again, whether it's telehealth or not, informed financial consent is sometimes a legal requirement, sometimes best practice, but just do it. It is best practice overall. Now, so let's get into telehealth now. So a couple of myths, just do a little bit of myth busting. So we've had a lot of questions come through to us over the last week with a lot of confused practitioners. So geographical restrictions have gone. So for the specialists on the call, you don't have to worry anymore about that 15-kilometre rule that used to be in place. It doesn't exist anymore. We have whole of population telehealth. So you can do a telehealth consultation to a patient next door, in the room next door. You don't have to worry about those geographical barriers. Specialists, there's no 12-month rule. I heard some hospital-based specialists the other day saying that they can only do telehealth if they've had a face-to-face consultation with the patient in the last 12 months. That's incorrect. That rule applies to GPs. We'll come to that in a minute. It does not apply to specialists. I've also heard people in the last couple of days saying we're not allowed to see more than 30 patients in a day. That is also incorrect. There is a new 30-20 rule. I'm going to talk about it in more detail in a minute, but it is not coming into force until the 1st of October, we are told. The other thing to just be aware of for specialists, all those old loadings are gone. So, you know, surgeons and dermatologists, you used to do 104, 105 plus a 99. 99's gone. So for physicians, you used to do your 110s and 116s with a 112. 112's gone. All those loadings are gone. For any psychiatrists that are on the call today, many of you might have heard that in the lead up to the recent federal election, then opposition health minister Mark Butler said that he was going to reinstate item 288 for the telehealth psychiatry. He's now in government, obviously, but that item has not yet been reinstated. We don't have any further information on that. If any of you do, please share it. But I've had a good look around today. I can't see any indication about that. And certainly on our current data file, that is the current file that everybody is using out there, there is no item 288. So it may or may not come back. The other thing to know is that patient end support services are gone. Essentially gone. There's a little bit left. They retained optometry practice nurses and Aboriginal and Torres Strait Islander health workers can do patient end support, but all those old GP end support services have been removed. Just a note on that for the GPs who are with us here today. What I have heard anecdotally is that quite a few GP practices are charging a fee to patients who choose to come to their practices to have a specialist telehealth appointment with the GP present, charging them a fee without a Medicare rebate. That's perfectly legal. You can do that if you want to. And I am hearing that some GP practices are doing that. So I just wanted to make that clear. There's nothing illegal about that. Just make sure you don't put an item number on that service. That's just a straight out-of-pocket cost for the patient. So let's have a little look now at GPs. So we'll start with GPs. I've got a lot of legislation up here next to me, so forgive me if I look to my right, because I've got a lot of legislation up on the screen here. So the 12-month rule, let's just have a little look at that. So there is a rule that is continuing that certain services can only be provided, these telehealth services can only be provided if they are performed by the patient's usual medical practitioner. What does that mean? Usual medical practitioner means a medical practitioner other than a specialist or consultant physician. So there you are, or the specialist on this call, it doesn't apply to you. You don't have to have seen the patient face-to-face in the last 12 months. So a specialist, patient's usual medical practitioner means a medical practitioner other than a specialist or consultant physician who has provided at least one service to the patient in the past 12 months or is located at a medical practice at which at least one service to the patient was provided or arranged by in the past 12 months. And the definition of service expressly excludes any telehealth service, whether video or phone. So that's the face-to-face requirement. So that continues. Now, there are exemptions to the usual practitioner rule, and I'm reading from the legislation. The exemptions are a person who's under the age of 12 months, a person experiencing homelessness, a person who is in COVID isolation because of a state or territory public health order, a person who is in COVID-19 quarantine because of a state or territory public health order, a person who receives the service from a medical practitioner located at an Aboriginal medical service or an Aboriginal community controlled health service. I'll just pause there. Just be really clear about the wording of that, because I have seen people get confused about that. They think that they have been able to, for example, be in Melbourne or Sydney and provide a service to an Aboriginal medical service. That is not how that provision works. It is a person receives the service from a medical practitioner who is located at that Aboriginal medical service or an Aboriginal community controlled health service. And then the last exemption is a person who is in a natural disaster affected area. Now that's recently changed, very recently. That used to say a flood affected area. They've now changed it to say a natural disaster affected area, which makes it broader and, you know, anticipates things beyond floods, so fires that may affect people. Now, the other exemptions, people that do not have to have that 12-month rule are bloodborne viruses, most mental health services, smoking cessation, and sexual and reproductive health. So that's sort of the overarching requirements of the usual medical practitioner. Now, a lot of GPs last year, or I think it was early this year, got caught out by that rule because it's a rolling rule. So every time you see a patient, you have to have seen the patient in the last 12 months from the telehealth service you are providing today. So I think what a lot of people mistakenly thought is that I'll have a face-to-face consultation with the patient. That's it. I've kicked off a 12-month period and everything I do after there is going to be okay. It wasn't, because you had to have had a consultation, face-to-face consultation with the patient in the preceding 12 months for every consultation. So just be very, very careful about that. So let's move now to the removal of most of the telephone services. So a lot of telephone services were removed on the 1st of July. And we are now, there's predominantly video services. So what is left is for GPs, you've basically got a short consultation and a long consultation. There is another long consultation over 20 minutes for patients in Monash modified areas 6 and 7. And again, the rule applies in the same way as that previous rule I just described. It's not that you can be in Sydney and provide a telehealth service to someone in an MMM 6 or 7. That service has to be provided from a medical practitioner in that practice, and that practice is in MMM 6 or 7. So just don't get caught with that. You have to be very careful about that. What we were told on Saturday, and I've got the minister's announcement up here on my other screen. What we were told on Saturday is that Level C GP phone consultation, phone, not video, phone consultations are going to be reinstated this week for the express purposes of assessing and providing antiviral COVID medications to patients. So I've been glued to the internet and social media and the legislation over the weekend and this morning. It's not there yet. But what we believe is that any day now, we are going to see level C item number for GPs reinstated on a phone basis. However, I suspect that it's not going to be just a level C. I suspect it's going to be a new item number, a bit like the assessing patients for COVID-19 vaccines. It appears that it's going to be a similar item number that is the equivalent of a level C in terms of the dollar amount and the time requirement, but it's going to expressly state something like, for the purposes of assessing and prescribing antiviral medication for a patient suffering from COVID-19, something like that. To stay up to date, you can log into our FAQs that we do every day. So one of the things that I wanted to talk to you now about is the 80-20 and 30-20 rules, because I know that they give people a lot of grief. So there's always been an 80-20 rule. So the 80-20 rule, I've got it up here on my screen in the legislation. For the purposes of Section 82 of the Act, circumstances in which services rendered or initiated by a medical practitioner constitute a prescribed pattern of services are that A, the medical practitioner renders or initiates 80 or more relevant services on each of 20 or more days in a 12-month period, or subsection B, the medical practitioner renders or initiates 30 or more relevant phone services on each of 20 or more days in a 12-month period. So let's just pause and break that down. First thing is, I'm reading the legislation. That legislation is in force right now. It says in force, latest version. So it says the 30-20 rule is in force today. Now, what we know, however, is that the minister has announced that is not going to be enforced until the 1st of October. You also have it on the Medicare website that the 30-20 rule has been postponed and is not going to be enforced until the 1st of October. I've taken screenshots of everyone who's ever said that. I suggest that you do too. So I doubt that anyone would dare. It would be outrageous if they would dare to now backpedal on that and enforce that. So the 30-20 rule is not in force at the moment, even though it's on the Federal Register. I suspect that they just haven't had time to update the legislation yet. But I will tell you a little bit about the two rules. The 80-20 rule. So the 80-20 rule is 80 or more relevant services, and relevant services are defined by reference to the Medicare schedule and all the groups and subgroups. So basically, relevant services mostly, almost exclusively, affects GPs. So it's basically all of the items in group A40, subgroup 1, 2, 3, 4. So it excludes physician items, so item 110, 116, 104, 105, psychiatry items. It excludes all of those items. You are not captured by the 80-20 rule. It's really exclusively GPs. The only specialists who would be caught by it is anyone claiming the unreferred item numbers, which we do see from time to time, but it's pretty unusual. One of the things you need to know, GPs, is that under the revised definition of the 80-20 rule, relevant services now include a whole lot of your telehealth services as well. So it used to be just face-to-face services. If you did more than 80 services on 20 days in a 12-month period, you would be caught. But it's not just face-to-face services now. It is your telehealth services and telephone services as well. So be very, very careful about that, please. Just remember also the 80-20 rule and the 30-20 rule are deeming provisions. So what that means is it removes discretion for the relevant authorities. They're deeming provisions. So if you do this, you are deemed to have engaged in inappropriate practice. So there's no discretion to not refer you to the professional services review, you're going straight there. You're not going to pass go. So please be very careful, not get caught. If you want more information, if you want detail about does this service fall within the 80-20 rule? Does this service, please come to me. I'm really happy to help you with that. I don't want to see you caught. So please shoot through a message on our various channels and I will come back to you on that. 30-20 rule, I think we should have a quick look at it because it is coming. 30-20 rule affects everyone, not just GPs. So that'll be good news for GPs. It doesn't affect allied health though, psychology. And I think the reason for that is psychology services, by and large, the minimum time requirement is 20 minutes. Mostly it's 30 minutes. A lot of it is 50 minutes. So, I mean, I don't think there's any need for a 30-20 rule for them, and I'm sure the department was thinking along the same lines, because if you were providing 30 20-minute services, you'd be working 10-hour days, and if you're providing 30 50-minute services, there isn't that many hours in a day. So it probably doesn't need to apply to allied health practitioners who are doing mental health services, but for GPs and specialists it does. Now, something really important, the 30-20 rule, the relevant wording there is relevant phone services, and that's a different category. Again, there's two different definitions in the law. One is relevant services, and they're all listed. Separate to that is relevant phone services, and they are all listed. And there is some overlap, but there is also some difference. So key things for specialists to know from the 1st of October. Your item numbers, so physicians I'm talking about now, so your equivalent of item 119 is included in the 30-20 rule. However, for surgeons and dermatologists and everyone who claims item 104, 105, your equivalent telephone service of item 105 is not included in the 30-20 rule. It's quite interesting. I suspect the reason for that is because the majority of 105s are not claimed, because the majority of post-operative care you can't claim anyway. You go and visit the patient and you have to do what you have to do post-operatively because it's all aftercare and you're not allowed to claim it. So I suspect that's the thinking there. However, it does mean that you could claim the equivalent of 105s for something that's not aftercare, and you can do more than 30 in a day and you won't get caught, whereas your physician colleagues doing 119 telephone equivalents, you will get caught if you do more than 30 of those a day. Something for physicians and surgeons to be mindful of, I've seen people get caught, is the new telehealth equivalents of your 110s, 116s, 119s, 104s, 105s are a minimum of 5 minutes, whereas your 110s, 116s are not. They're not time limited. But the telehealth equivalents have a minimum, must be a minimum of 5 minutes. And I've seen people get caught. We've had a patient come to us and complain. He recorded the time of the consultation on his phone, pressed start time, finish time, took screenshots and said this phone consultation took 3 minutes and 20 seconds. It did not take 5 minutes. I've seen what the doctors claimed. It was a haematologist. I've seen what this doctor's claimed. It's a fraudulent claim. I want my money back. So we had to sort all of that out. So please be very, very careful about this 5-minute requirement. So we're getting very close to the end. We've got about 5 minutes to go. Usual medical practitioner we've covered, exemptions we've covered, 80-20, 30-20 rules. Provider numbers, use your usual provider number at your usual practice. When the department implements a lot of things, sometimes I think they only think GP, they can't think beyond GP. That's fine for you if you're a GP and you've got a usual practice, but a lot of GPs even don't have a usual practice anymore. They practice in 3 different practices, but specialists just don't have a usual practice. Like they are just, we have specialists that have 10 provider numbers and they're all over the place all the time. But you have to decide what your usual practice is, and bill using that provider number. The other thing you can do is get a provider number linked to your home address. And in fact, since 2020 and the introduction of COVID telehealth, we've had a lot of doctors who've decided that they're going to do telehealth from home, and they had to be at home very often. And so a lot of providers have got a home based provider number that they use. And I think we probably should end there, as I said, rapid fire. Oh, one thing just to be very clear about GPs, your residential aged care facility phone-based services for review of a mental health treatment plan that are not time-based are captured by the 80-20-30-20 rules, so be very careful about those as well. And I think with 5 minutes to go, we probably should end it there. That was fast. That's a lot of talking. I hope that helped. But let's have a look at questions. I'm just going to go from the top. Lots of hellos. Hello, hello. How do the changes affect psychiatrist telehealth to people in the bush? Oh, good question, actually. Psychiatry telehealth to the bush, you've actually had your phone services removed as well, other than for subsequent consultations. You have retained 3 telephone services. I think it's items like your 297, 300, 306, something like that, those 3 item numbers. You're able to provide telephone, and you need that for the bush. Let me come to dropouts. But it's not for initial consultations. As I said, we're waiting on the minister to see whether he's going to come good on what his pre-election promise to reinstate that loading at item 288. Dropouts. I think dropouts are important. We've been doing work in the bush, like many of you, across the course of COVID, and it's a very, very big problem, right? Dropouts all the time. There is not stable internet anywhere in this country, but certainly not in regional and remote parts of Australia. What do you do if it drops out? So you're halfway through a telehealth a video consultation, and the connection drops, and then you pick it up on the phone. What do you do? Which item number do you claim? The best advice is, if you feel that what you did while you had the video connection met the requirements of the item number, you can claim the item number. If it didn't, don't claim the item number. Medicare and the PSR, as you would all know, show no mercy when it comes to the strict requirements of these item numbers. The best advice, therefore, is to explain that to your patients. If you've had video connection and it suddenly dropped, and then you pick up the phone and you're on the phone for the next 45 minutes with the patient, you no longer meet the requirements of the item number. You'd have to explain that to your patient and say, look, unfortunately, we don't meet the requirement of video. I'm going to have to charge you. You'll have to pay the full amount for this consultation. It's X amount, and there will be no Medicare rebate for it. That's the best advice. Don't risk not meeting the requirements of the item number, because you will get no leniency anywhere if you end up in front of Medicare or the PSR. Someone said hi from Dubai. That's lovely to have people from Dubai on the call. Anything else? Andy, is there anything else? Changes for psychologists? Okay, look, good question. The short answer is no. There's no changes for the item numbers for psychologists. What is a little bit confusing for psychologists, and I get a lot of queries about this, is how to manage the 10 services, the 12 services, the 18 services, the 6, the 4, the extra, like this insane sort of, system of sending patients back and knowing when. But really the item numbers have not changed. The requirements have not changed, which is good news for allied health providers. The other good news for allied health providers is that you're not captured, as I said, by the 80-20-30-20 rules. And it'd be pretty obvious if you were doing 30, 50-minute consultations in a day, probably wouldn't add up. So not too many problems there for you. look, the only thing is, if you're confused, as many of your colleagues are, and I find it complex too, about how you manage the referrals and so forth, please just send me a message offline. One thing I would say, because I get asked a lot by psychologists, does a GP referral to me for allied health psychology have to state the number of services? The actual answer is no, and it's nowhere in the legislation. And that's actually consistent with the overarching requirements of the Medicare scheme, which is that if a GP was to require you to do 6 services, what if the patient only needs 3? Like, you as a clinician decide what services are clinically relevant for this patient. So if the patient only needs, remember, clinical relevance necessary, if the patient only needs 2 sessions with you, only do 2. Don't do 6 if the patient doesn't need 6. So that's why it's not a legal issue. It's a internal management and compliance issue as to whether you go back to the GP and say, you tell me how many you want me to do, or you're happy with the referral that says you decide how many. That's really an issue for you, but I can talk about that more offline. I think we have to wrap it up there. It's now, according to my computer, 1 minute past 1. Thank you very much for attending, everyone. I hope that has been really helpful for you. Anyone who came in late, just listen to it again when Andy sends you over the recording, because I did talk about specialists earlier on. And any other questions can be answered in the LinkedIn comments. So thanks very much, everyone, and I think we'll wrap it up there.